Guys, I'm back. I'm your Dr. Leander, and today we are going to talk about a topic, a suspected case of DDH, and what are the investigations you do, the radiological investigations. So, this video has been made keeping you in mind, the postgraduate, right before the exams, preparing and trying to grasp all the information. So, it's made in a way that all the information sticks in your head with mnemonics and a mind map. So all you need to do is listen to the video, watch the video, make notes, and then make the associations stick in your head. Imagine the lines and the angles which have been spoken about along with the images, and go through the notes in the app. If you do that, you will never forget the information in this video. And this topic has been chosen from the feedback received in the group. This is made for premium subscribers. Let's go to the video. Welcome to today's session where we'll be exploring the imaging techniques used in suspected cases of developmental dysplasia of the hip, or DDH. This is a crucial topic in pediatrics, and understanding it thoroughly will enhance our ability to diagnose and manage this condition effectively. Let's start by identifying the key risk factors for DDH. An easy way to remember them is with the mnemonic BFT. Breech position. Infants delivered in a breech position are at a higher risk due to the abnormal positioning of the hips during development. Family history. A positive family history of DDH significantly increases the likelihood in newborns. Torticollis. The presence of torticollis, which is a twisted neck, can be associated with developmental anomalies like DDH. Action point. It's essential that infants with any of these risk factors undergo ultrasound screening, regardless of how they appear clinically. Early detection is paramount in preventing long-term complications. Now let's delve into ultrasonography in DDH. Ultrasound is our imaging modality of choice before the ossific nucleus of the femoral head appears, typically before 4 to 6 months of age. However, we prefer to perform the ultrasound after the infant is at least 1 month old to reduce the high rate of false positives seen in the first month. The purposes of ultrasonography are twofold. Dynamic assessment. It allows us to assess the stability of the hip joint in real time, giving us valuable information about joint movement and alignment. Monitoring development. We can monitor acetabular development over time, which is especially important for infants undergoing treatment with a Pavlik harness. One widely used ultrasound technique is the Graf method. Think of it as graphing alpha and beta procedure. We position the infant on their side and obtain a coronal view of the hip. This standardizes our approach and ensures consistent measurements. Measurements alpha angle. This measures the bony acetabular roof coverage. It tells us how well the acetabulum is covering the femoral head. Beta angle. This evaluates the cartilaginous acetabular roof coverage, providing insight into the development of the acetabular cartilage. Focusing on the key angles in ultrasound imaging, alpha angle, remember A for above 60. Formation. It's the angle between a line along the ilium and a line over the bony acetabular roof. Normal value greater than 60 degrees. Interpretation. An angle below 60 degrees suggests acetabular dysplasia, indicating the acetabulum is too shallow and not adequately covering the femoral head. Beta angle, think B for below 55 formation. It's formed by a line along the ilium and a line tangential to the labrum. Normal value, less than 55 degrees. Interpretation. Higher values may indicate that the femoral head is not properly seated, suggesting subluxation or potential dislocation. Let's shift our focus to radiographic imaging, specifically X-rays. Radiographs are recommended after the proximal femoral epiphysis, which usually occurs around 4 to 6 months of age. At this point, X-rays become more effective and less dependent on the operator's skill compared to ultrasound. Key lines and angles on X-ray include Hilgenreiner's line, think horizontal hip line. It's a horizontal line drawn through the top of both triradiate cartilages, serving as a baseline for other measurements. This line helps us assess the vertical position of the femoral head. Perkins line, remember perpendicular Perkins. It's a vertical line drawn from the most lateral edge of the acetabular roof, perpendicular to Hilgenreiner's line. Normal position. The femoral head ossific nucleus should be located in the lower medial quadrant formed by these two lines. If it's displaced laterally, it may indicate subluxation or dislocation. Shenton's line, think smooth Shenton. This is a curved line along the inferior border of the femoral neck and continues along the superior margin of the obturator foramen. Normal, it should form a continuous smooth arc abnormal. A break or discontinuity in this line suggests displacement of the femoral head. Acetabular index, angles improve with age formation. It's the angle between Hilgen-Reiner's line and a line drawn along the acetabular roof. Normal values newborns, up to 40 degrees is acceptable. By 4 months, the angle should decrease to 30 degrees or less, reflecting normal acetabular development. Center edge angle of Weiberg, think widening Weiberg description. This angle measures how much the acetabulum covers the femoral head, which is critical for joint stability. Formation, it's the angle between a vertical line through the center of the femoral head and a line from the center to the lateral edge of the acetabulum. Normal values, ages 6-13, greater than 19 degrees indicates adequate coverage. Ages 14 and older, greater than 25 degrees is considered normal. To help cement this information, here are some mnemonics, risk factors, BFT, breech, family history, torticollis. Alpha angle, A for above 60 degrees, think of aiming high for normal development. Beta angle, B for below 55 degrees, keeping it low is good here. Hilgen-Reiner's line, horizontal hip line, our baseline reference. Perkins' line, perpendicular Perkins, standing tall and straight. Shenton's line, smooth Shenton, a continuous curve without breaks. Acetabular index, angles improve with age, reflecting normal growth. Weiberg's angle, widening Weiberg, greater angles mean better coverage. Here are some strategies to enhance your understanding and memory. Visual associations. Associate each concept with a vivid image. For instance, imagine Perky Perkins as a rigid, upright line safeguarding the hip joint. Storytelling. Create a narrative that links all the mnemonics. Picture a breech baby with a family history of DDH and torticollis, undergoing an ultrasound where we focus on alpha and beta angles. Active engagement. Regularly test yourself on these concepts. Discuss them with peers or use flashcards to reinforce your memory. Teach back. Explaining these topics to someone else is one of the most effective ways to solidify your understanding. Finally, let's apply some Cognishift memory techniques, mind mapping, draw diagrams connecting the risk factors, imaging techniques, and key measurements. Visual representation can make complex information more digestible. Spaced repetition. Review this material at increasing intervals to move it from short-term to long-term memory. Clinical correlation. Whenever possible, relate these concepts to real patient cases you've seen or studied. This practical application reinforces learning. By integrating these imaging techniques and memory aids into your studies, you'll be well prepared to diagnose and manage DDH effectively. Remember, our goal is to ensure early detection and intervention to provide the best outcomes for our young patients. Thank you for your engagement today. It's been a pleasure discussing this important topic with you. If you have any questions or would like to delve deeper into any of these areas, please don't hesitate to ask. Let's continue to learn and grow together as we strive to provide exceptional care.